drug first and explain the patient lifestyle issues, prevent all the factors which precipitate the seizures, and so on. The step one. There are 8 conditions which can mimic a seizure. And the first 2 of them are the commonest, the syncope and psychogenic or non-epileptic seizure disorders. 2 common conditions. Migraine headaches, brain ischemias, like TIAs for example, movement disorders, sleep disorders, metabolic conditions, and breath holding spells are the few examples which can mimic a seizure. However, the first 2 are important because they are very common, and syncope is 100 times more common than the seizure. So therefore, before we make a diagnosis of seizures or epilepsy, make sure patient doesn't have a syncope or patient may not have a psychogenic or a pseudoseizure. Now, syncope is just to, what about syncope is very common, it's sudden fall by the person, and patient may have injuries uncommonly in syncope also. And if you read Harrison's textbook, which I mentioned, I've given the reference also for all you read, is that cold extremities, minor myoclonic jerks, mild flexor extensor posturing, and urine incontinence can also occur rarely in a syncopal attack. Now, all these conditions will make you feel that patient probably might be having a seizure. So therefore, please make sure by your history of the patient, which you take in detail, that patient is having epilepsy or having a syncopal attack. Then, regarding pseudoseizures, again very common. So I will just show you 4 videos of pseudoseizures. I'll show you 4 videos of focal seizures. I will show you 6 videos of generalized seizures. And once you see those 14 videos, you will be really in a very easy way, you can obviously diagnose and treat the patient with epilepsy. So therefore, these symptoms are symptoms of pseudoseizures. Now, first patient. Now this girl has come to us and the patient has brought this video to us. She has this movement disorders during sleep. She appeared to be sleeping, but she had these kinds of jerks which patient had, and see again, and this could be labeled as a seizure unless we have to be very cautious and thoroughly vigilant to diagnose the patient. Then patient may have side to side head movements and pelvic thrusting with violent bizarre shaking of the body. This child is having an EEG, and you can see he's having his leg movements and also having a thrusting of the pelvis up and down. Now this kind of patients can also lead to another problem, and that is the EEG can become disturbed. So you will think patient has a normal EEG record, and this could be a case of epilepsy, but this is basically a pseudoseizure. See again once. A very short videos I have brought for you, so therefore this kind of movements can be a part of pseudoseizures and not a part of epilepsy. Now, again, a patient may have again very, very vague symptoms of movements of the upper extremity, lower extremity, 2 legs and 1 arm also, which can confuse somebody or even the observer that patient might be having a epilepsy. Now this girl is moving her both the legs. She's moving her now, her right hand also. She's sitting upright in the bed and looks to be unconscious, but she is rather fully conscious. See again. Third video, in which patient has movement disorders while sitting on the bed, and it looks just like a seizure, but probably it's not a seizure. It's true, it's probably a pseudoseizure. And the 4th video is this one, in which the girl presents with very severe right-sided focal movements, and she's groaning in pain. The jerky movements of the right hand, the patient is fully conscious. Obviously, this could be a case also of a focal, simple focal seizures also, but this case turned out to be a case of pseudoseizure. So these are the 4 varieties which I have shown you, in which patients can be confused to be having a epilepsy. The step 2 is decide whether patient is having a focal seizure or generalized seizure. It's not that simple to decide, because the onset is so rapid, it's so sudden, the patient can't tell you that whether it was right-sided or left-sided. But sometimes patient can tell you that my movement started from the right hand or left hand or the right leg or the left leg. Or patient may have history of aura, which will signify that patient probably is going to have or had a focal seizure. The presence of aura will give you a very good insight in a patient that patient might be having a focal seizure. Why it's important? Because the treatment part will depend on the focality, whether it's focal or there are different treatment for either of them. So now I will show you 4 videos of focal epilepsy. Focal epilepsy can be simple focal, patient remains fully conscious. It can be complex focal, patient can become unconscious. The second, the patient may have a generalization after the focal seizures and become unconscious, the 3rd variety. And the 4th variety is automatism. Automatism is something very interesting, which all neurologists want to, I think, see or find out in their own patient, because it is very subtle finding, which often missed by most of us. Simple focal. Now, simple focal seizure is this seizure, which the patient is sitting comfortably on the couch, on the stool, and you will see very, very minor, short-lived, right brachial twitchings movements, which could be a patient having a focal seizure, simple focal, because patient is fully conscious, he's sitting comfortably on the chair. The second is a focal complex. You can diagnose very easily, because the patient happens to bring you with a video of this particular type. You will say, oh, this patient is having a focal seizure or epilepsy, no doubt about it. But just have a look at the video of this patient, that she has a focal with complex variety, that her left hand is having jerky movements. The girl is not conscious, she is semi-conscious. She also had facial twitchings also, probably as a part of facial automatism. So left focal seizures with unconsciousness is a very common presentation of focal seizures, in which patient can become unconscious. And the 3rd variety, focal seizure with generalization. This particular patient is having focality of the seizure followed by, began with the right hand, then became it also went to the left hand, his face is twitching, and then after some time it also came in both the legs. So it is a focal seizure beginning with the right hand and becoming generalized. This is a 3rd variety of focal seizures. And the 4th variety of focal seizures is automatism. A very, very subtle and a very interesting finding, which you will see in this video. And they are often missed, often not diagnosed, because patient may not be unconscious. This patient is having a problem during sleep. Suppose you have a patient sitting in front of you in the clinic, and he has automatism. You will think patient probably might be having chewing movements of the mouth. He's eating pan masala, eating chewing gum. But at that time, patient is not fully conscious. He is not fully aware what's happening around him. That's automatism. Now see here. This patient is sleeping, and he's having the movements on the right of the face. This is classical automatism. Dr. Varsha, you are here. I think you agree with this. Dr. Zubair. This is a patient made video. He brought it to me from his own house. So therefore, I just preserved this video. This automatism. This is a very interesting finding, which can make you, guess this patient probably be having a automatism as a part of focal seizures. So investigate accordingly. So now, I will tell you the next variety, generalized seizures. By the way, just to make you remember this important point is that focal seizures are very common, about 75 to 80%. Generalized seizures are not that common, 20%. But however, this variety of seizures or epilepsy are maybe bread and butter for neurologists because they are, or they go on for a long treatment with you. So therefore, it's important for all of us to know about these 6 varieties of generalized seizures. This is basic synergy of the seizures: tonic, clonic, atonic, generalized tonic-clonic, the commonest which you see, absence, and myoclonic. Tonic alone, clonic alone, or atonic alone occur in children who are neurologically handicapped. They may have spells here, they may have CPA, they've got other illnesses. So they occur only in children who are neurologically handicapped. GTCAs, the 4th variety, obviously can occur at any age. The 5th and 6th also occur in young age. And myoclonic epilepsy is a classical myoclonic epilepsy seen in adolescent girls, which is called as juvenile myoclonic epilepsy. So this is a part of, this is not purely a tonic seizure, but just to show you the video. Initially she had tone increase in the body followed by generalized tonic-clonic movements. The second variety, the clonic movements, I told you in children. This child who has, as you all know, in epilepsy you have the first phase is tonic phase, the second phase is clonic phase, the third phase is tonic-clonic phase, followed by frothing and followed by, post-ictal stage. That's the 4 stages. So this child may only have a clonic phase, and this occurs only in those children, as I mentioned to you earlier, in neurologically handicapped kids. So it is basically clonic. There is no tonic movement seen. Classical case of clonic seizures in a small child. Now, the next variety is a atonic seizure. Atonic seizure is also characterized by sudden drop of the body, just like that. People draw, just a fall down. Our patient may only also have head drops for a very brief period. Head drop. And you have to be very vigilant and very careful to see. The observation has to be obviously of highest order to see this patient. Just look at the video. Now this child has or is having atonic type of movements in which the head drop is taking place, and here it comes. So this is, I think, very, very subtle. You have to be very, very careful to see whether that patient, when does he have this. See again, it coming in the later part of the video. That is a atonic seizure. So we go to the next one. Yeah, the classical GTCS, which you all see in your clinical practice, obviously a very, I think, formidable, very, very bad appearance. The patient, he is having a generalized tonic-clonic seizures with injuries on the face, tongue bite, and incontinence, which can take place. Classical example of generalized tonic-clonic seizures. And the next variety is a case of absence seizure, which you don't get time to record that patient because you hardly get time to record the absence because it's very sharp, very brief actually onset. But just see here, we could get this in this patient. This certain head movements, basically very short, partial, very short-lived movement is a part of absence seizure the patient is having. Right. The next one. This is a case of myoclonic seizure. So the whole body jerks like anything. Patient may be fully conscious, but the body jerks. Just see that. So EEG findings are there to be, obviously we go for EEGs, but remember, EEG findings are not often very helpful in diagnosing our patient of seizure disorders, and it has been mentioned that many times wrong reports of EEG being positive make the clinician to start drugs for the epilepsy management, which is not correct. MRI may show findings like NCC and all these things. Then we have to make out the patient history, investigate the patient, and fit the case into particular diagnosis, whether which syndrome the patient fits into it. Now drugs actually. Now step 4 is drug selection in the patient of seizure disorders. We have 4 older drugs, Gardnerol, phenytoin, carbamazepine, valproate, which we are using even today, Out of all the four, the maximum used drug at present in this group is carbamazepine, which is the wonder drug, or carbamazepine is the basic drug to be used for focal seizures. Valproate again was a broad spectrum drug with still much less drug, but due to side effects like weight gain, tremors, hair fall, and POCD, we don't use this drug, especially in females. Then lamotrigine is again a wonder drug. It is used for all kinds of seizures, focal and generalized. Levetiracetam again is being used for both focal and generalized seizures. Lacosamide is basically used as first-line treatment for focal seizures, also can be used for the generalized seizures. Brivaracetam is used basically as a first-line treatment for focal seizures and also in those patients who cannot tolerate levetiracetam. Topiramate we don't use much for epilepsy. Parampanel is used basically for refractory seizures as for add-on therapy in patients who are not controlled with other drugs. This is the list of all the drugs which we are using today, all the newer drugs. There are 16 drugs. And now, this is the main slide, which you try to remember that. And this is the one which we're talking about. For focal seizures, the drug of choice remains to be carbamazepine, oxcarbamazepine, lamotrigine, lacosamide, and levetiracetam or brivaracetam. And for generalized seizures, we use levetiracetam, valproic acid, lamotrigine, and lacosamide also as a first-line treatment. For reflex epilepsy, we can use valproate therapy. So, again, I mentioned to you in the first slide is you must remember the 4 steps: diagnosis first, type of seizure then diagnosis, and the fourth is the drug selection. And the other factor which can precipitate the seizures. And finally, last video of this presentation is one in which it is one of my favorite videos in all epilepsy presentations. This child had movement disorders, and I will like if residents can tell the diagnosis in this case afterwards when the discussion is going on. So I can treat 3 residents who come with the correct diagnosis with a cup of coffee at my house. This is a not so simple case, by the way, but just look at the video. This is my last slide. The child has right focal movements, right facial twitchings, then left-sided twitchings, then right focal twitching from the face. The child is throughout conscious, fully conscious. So he had a conscious child with vague movements of the right side of the face, right arm, and also of the left arm. So 3 residents, if they have come here, they can answer this query, and we can meet afterwards. Thank you very much for our patient hearing.
Thank you, sir. Thank you very much for very lucid presentation of this very vast topic, epilepsy. So I would ask for any question from audience, and particularly the answer of that video. Anybody can answer? Dr. Richa and Dr. Varsa.
चाय नहीं कॉफी मिलेगी नहीं कोई तो होगा भाई, ऐसा थोड़ी है कि कोई ना इतना बड़ा देखिए इतने ऑडियंस बैठे हुए हैं. You have the coffee anyway, doesn't matter. But let someone come out.
So
Anyone,
somebody is
bhai, any
answering at the
resident?
back.
Yes. हाँ? No. टॉयलेट में तो आवाज़ निकलेगी यार. आवाज़ नहीं. हाँ, you are right, but टॉयलेट में मूवमेंट्स कहाँ होते हैं इस तरह के, है ना? हाँ. Is anyone? Partly correct, sir. But actually, patient is fully conscious. If patient has that particular, he will be unconscious. Then only you generalize to the other side. I tell the diagnosis in this patient. This patient initially came with right-sided hand movements. I thought it is a functional case, psychogenic case, because he was having right-sided movements, right facial movements, and also on the left side. How can you explain that? So I got the case investigated. There was a huge tuberculoma in the brain on the left side. He was fully conscious. Tuberculoma causing right-sided simple focal seizures with psychogenic seizures in the left hand. This is what it is. This is what it is. Otherwise, how can you explain? Because you see, you can't explain this. Because I never thought it is a case of tuberculoma. And I have got a CT also with, I think, very old case. I've got the MRI with me, preserved with me. So I have not shown it here. But anyway, any comments from the panelists? They are here. They can throw more light on this.
Yes, sir, definitely. The lesion, if the patient is fully conscious, then the opposite side movements cannot be explained.
Cannot be explained
Yes.
without being unconscious.
But of course, we cannot rule out organicity in view of tuberculomas.
I think possibly he is a small child, so he is mimicking the movements on the opposite side also. Because very small child.
Exactly. He's mimicking. That's what I said. It is a pseudo-seizure basically.
Once you have find out that organic lesion is there, so there might be one possibility that tuberculoma, if they are not able to produce particular epileptogenic focus, some current, some sort of discharges can go through the commissural fibers like corpus callosum to the opposite side.
Let Zubair answer this question.
so
There
that
are fresh
little-
MDs, DMs from fresh DMs. Tell the answer.
I think it's very unlikely, sir. If the discharge is so much that they will cross through the midline, then the patient will become unconscious. Must go.
Must go. Not very common, because they are often confused with TIAs, you know. But I don't see many. Maybe you have seen. You see, unless a lesion is involving the parietal cortex, sensory cortex, तभी वो sensory symptoms उसमें patient में आएंगे, है ना? So normally what happens, it is involving the motor part also and the sensory part also. So you have sensory motor actually presentations. So sensory seizures can occur in those patients, for example, who are having a brain tumor in the sensory cortex, sensory area only, not involving the motor cortex. Otherwise, patient will have both kinds of movements. But anyway, what I want to tell you to summarize the whole issue is that, remember, just take a message from whatever I have read is that epilepsy is not that common as compared to syncope or pseudoseizures. Please keep in mind that. It's a very important point to take home message. And many patients of seizures tend to develop psychogenic seizures. Very difficult to treat in those situations, very difficult to treat. I had a patient from, I should not name the institution, from Delhi, and diagnosed as a complex with automatism. Patient came to me and I said, it is not, it is probably a psychogenic seizure. And she had gone through all the tests, everything was normal, but labeled as automatism and psychogenic seizures from Delhi institution. After 3 months, they again came to me. And again, the same problem was there. She would not respond to treatment for seizures also, for pseudoseizures also at the same time. Then what happened was that I saw all the prescriptions of the patient from that institution. And I got one prescription from psychiatric department, which labeled the case as a psychogenic seizures. So it's very common to have a mixed picture in patients, or sometimes we can't even diagnose. I also did my mistake. I made mistakes sometimes in diagnosing epilepsy. I should not say I'm exception. Everybody makes. But try to minimize your mistakes in treating epilepsy patient. That's what I want to convey to all you. Thank you.
Thank you, Dr. Navneet, for a lovely talk and this lucid presentation. Now I'd like to hand over the mic to the organizing committee for further proceedings.
I would like to request Dr. A.K. Srivastava to please come and give memento to our speaker, Dr. Navneet sir. request Dr. Vikas Shukla to please give memento to our panelist, Dr. Zubair. And Dr. Varsha. We'll now proceed to our next session, which is nephrology session, and I would like to request Dr. Yuvraj Gulati to please come on the dais and moderate the session. Dr. Yuvraj is an assistant professor at GSVM Medical College, Kanpur. He did his MD in general medicine from GSVM Medical College and completed his DM in nephrology from SGPGI, Lucknow. He has 11 years of experience in nephrology and worked as an expert nephrologist. He has also participated in research work in various workshops under the nephrology department and published many papers. Please welcome Dr. Yuvraj. Next, I would like to call our panelist, Dr. Alok Pandey. He is DM Nephrology from SMS Medical College, Jaipur, Senior Consultant, Department of Nephrology and Renal Transplant, Regency Super Speciality Hospital, Lucknow. Please welcome Dr. Alok. Next, I would like to call upon Dr. Mansi. She's MD, DM Nephrology. She did her DM from PGIMER and RML Hospital, New Delhi. She's consultant nephrologist at Regency Hospital, Kanpur. Please welcome Dr. Mansi. Our next panelist is Dr. DP Agarwal. MD Internal Medicine from GSVM Medical College, Kanpur, Chief Consulting Physician in Critical Care and Diabetology at Madhuraj Hospital, Kanpur. Please welcome Dr. D.P. Agarwal, sir. Next, I would like to call upon Dr. Kirti Vardhan Singh. MD Internal Medicine from GSVM Medical College, MD Forensic Medicine and Toxicology from SNMC Agra. His experience of 7 years as consulting physician in Kanpur. Please welcome Dr. Kirti Vardhan.
Hello.
I would now like to request Dr. Yuvraj to please.
Good evening, everyone. First of all, I would like to thanks to the organizer for organizing such an enlightening event for this city. It was very essential to organize such a clinical updates to enlighten our knowledge further. Now it's my pleasure to invite Dr. Deepak Diwan sir, who is an alumni and senior of my own institution. So it's my pleasure to invite him for the talk. The topic of today's session is recent advances in CKD management. With the increasing incidence of chronic kidney disease, I'm sure for the long time, we only had fewer drugs like RAS inhibitors for the management of kidney diseases. But with the recent advances of number of drugs like non-steroidal MRAs, GLPs, and SGLT2 inhibitors. So these are the recent advances. I'm sure we will be getting enlightened about these more. Over to you, sir, for the future talk.
Dr. Diwal is MD DM Nephrology from SGPGI, Lucknow. He's Director and Head of Renal Science, Regency Hospital, Lucknow. Winner of Mukesh Srivastava Memorial Gold Medal in MD Medicine. Winner of Srimati Jai Devi Bhatia Memorial Gold Medal for producing the best thesis in MD Medicine. Dr. Diwan has published many research papers and drug trials in many renowned national and international journals. Please welcome Dr. Deepak Diwan.
Thank you, organizers, for calling me. It's very nostalgic because I did my graduation from GSPM and I have my seniors and teachers sitting in front of me and my juniors as well. So without much ado, I'll start the presentation. So I'll be talking about the recent advances in chronic kidney disease management. And here we see two healthy kidneys who are having dumbbells in their hands. So we should point to keep kidneys healthy of ourselves and our patients as well. So this is the slide, although this talks about the international data, but the Indian data is no different. So in 2017, we have around 843.6 million patients with diabetes, with chronic kidney disease, and approximately 1 in 10 individuals have chronic kidney disease, and Indian data is almost the same. So if we see 100 patients in our OPD, almost 10 will have some form of chronic kidney disease. And the individuals who are more susceptible to have chronic kidney disease, we all know, are individuals with diabetes, hypertension, elderlies, females, and so on and so forth. What is more important is not only the incidence of chronic kidney disease is increasing, the contribution it is having to the death is also increasing. So increasing death rate, there is a 41.5% increase in death rate from chronic kidney disease between 1990 and 2017 in this 27 years period. And by 2040, chronic kidney disease will be the 5th most common cause of death worldwide. And it's still the most common cause of death in countries like Singapore, Greece, and Israel. So chronic kidney disease occurs more frequently and has devastating consequences. This should prompt major efforts to develop preventive and therapeutic measures that are effective. The aim of these measures should be lowering the incidence of chronic kidney disease and slowing its progression. Among the causes of chronic kidney disease, diabetes, I think this is the pointer. Yeah. Diabetes, especially the type 2 diabetes, is the most common cause of chronic kidney disease. When we diagnose the chronic kidney disease, we have to take two things into consideration. So, CKD is, first, what is CKD? CKD is defined as abnormalities in kidney structure or function which should be present for more than 3 months and which have implications for health. The clinical diagnosis of chronic kidney disease is based on two factors, the urine albumin creatinine ratio and the eGFR. It is always the eGFR, it is never the serum creatinine. An individual who is 30 kg, 70 years of age with a creatinine of 1 will have a GFR of 20 or 30. And another individual with a creatinine, again with a creatinine of 1 who is 100 kg, 30, 40 years will have a GFR of 90. So it's the same creatinine of one individual will have a GFR of 20, another will have a GFR of 100. So it's never serum creatinine which we should talk about, it's always the eGFR. And we have now simple formulas in our mobile phones, smartphones, we can just put in our computers, or the labs are also giving eGFR. So whenever we talk of chronic kidney disease, we should never talk in terms of creatinine. It is always, always, always eGFR. The other thing that we have to consider is a urine albumin creatinine ratio. So we should get a urine albumin creatinine ratio. We get so many patients in our practice who are diabetic, who are being treated for so many years, and they did not have even a single urine examination done. And they land with advanced stage 5 of chronic kidney disease. So it is very important to get a urine albumin creatinine ratio in all our patients with diabetes. It is a simple test. There is no blood involved. You just give a sample of urine which we discard every day. So early detection of kidney function or impairment facilitates the appropriate diagnosis and treatment of chronic kidney disease. So this is a very important, this is a heat diagram of chronic kidney disease. So when we talk of chronic kidney disease, we have to classify the stage of chronic kidney disease. And as we can see, there are 5 stages of chronic kidney disease based on the eGFR. Stage 1, G1, G2, G3A, G3, G4 and G5. And then based on the degree of proteinuria. That is albuminuria, A1, A2, A3. And why is this important? Because as the GFR decreases, there is increased risk of all-cause mortality, cardiovascular mortality, and progression of chronic kidney disease. Similarly, as the proteinuria increases, there is increased risk of all-cause mortality and cardiovascular mortality and death. So if the patient is in the green area, there is low risk. The yellow area, there is a moderately increased risk. This orange or mustard area, there is a high risk, and red, there is a high risk of all-cause death, cardiovascular mortality, and progression of chronic kidney disease as well. CVD is the leading cause of death in patients with any stage of chronic kidney disease. The patient of chronic kidney disease will have a cardiovascular event. He will have, the cause of death will be cardiovascular. Most of these patients will not be able to progress to end-stage renal disease. So here the key is to control the cardiovascular health. It's not the chronic kidney disease. We diagnose the patient with chronic kidney disease and then we go on to control the cardiovascular health. So if we see as the stage of chronic kidney disease advances from 1 to 2, 3, 3B and 4 and 5, the cardiovascular mortality increases. Here it is 27.5 and it increases up to 58. So more than 1/4 of patients with CKD stage 1 and 2 and more than half of the patients with end-stage kidney disease will die from cardiovascular disease. So they will not reach the end stage of the chronic kidney disease. They will die of the cardiovascular disease. This is again a very beautiful slide and it shows that eGFR of less than 75 and UACR as low as 30 milligram per gram is associated with increased risk of all-cause and CV mortality in chronic kidney disease patients. So if we see this, this is GFR 75, GFR 75, and this is the all-cause mortality. So as the GFR goes below 75, there is increase in all-cause mortality and CV mortality. Similarly, as the proteinuria goes less than 30 milligram per gram, there is increase in all-cause mortality and CV mortality. So this tells us about a multifactorial pathway in the renal disease progression. So there are CKD related factors like dyslipidemia, metabolic acidosis, hyperuricemia, then there is proteinuria, hypertension, reactive oxygen species, altered calcium phosphorus metabolism, anemia, oxidative stress, inflammation, nutritional smoking. This is important because once we have a patient with chronic kidney disease, we have to control all these factors. It's not just about blood pressure or sugar, so we have to control all these factors. This again tells you about the same things. So whenever we have a patient with chronic kidney disease, we have to have immunization, so because these patients are more susceptible to infection. There should be judicious use of potentially toxic medications like NSAIDs, aminoglycosides, other drugs. There has to have lipid management, the blood pressure management is there. We need to have weight reduction, glycemic control, and then there are specific medicines for glycemic control in patients with chronic kidney disease. It is not that all these medicines can be used. Then we should have a plant-based diet, physical activity is there. For few patients we have to do genetic testing, and then counseling and risk assessment has to be done. So again, this is I think everybody knows about this, but still, this is the overview of traditionally established therapeutic measures in reducing CKD progression. So initially there is renal hyperfiltration, so we have to do primary prevention. Then there is emerging or worsening albuminuria, we go in for secondary prevention. Then there is declining GFRs, we have to do tertiary prevention, and there is emerging or worsening uremia. So primary CKD prevention is control of risk factors like obesity, diabetes, hypertension, polycystic kidney disease, those individuals who have a solitary kidney, either genetic or because of the nephrectomy for some reason. Those individuals who have a high salt, high protein intake, those who have inadequate hydration, those who have genetic predisposition and other risk factors. So here we identify the at-risk persons, manage obesity, improve glycemic and blood pressure control, avoid high salt diet. One word about the high salt diet. Whenever we ask individuals to take a low salt diet, we should tell them not to take other salt substitutes like Lona salt or Tata Light. They have, instead of sodium chloride, they have potassium chloride, which might be detrimental in patients with chronic kidney disease. So we have to tell them you take normal salt in less quantity and avoid Lona salt and Tata Light. Encourage healthy food and lifestyle. Secondary prevention is then once we have diagnosed the chronic kidney disease, we have to slow down the progression, we have to delay or defer dialysis transition, we have to control the uncontrolled blood pressure, high protein diet, acidosis. So early detection and deletion, better control of blood pressure. Then we have RAS inhibitors, SGLT2, low protein and high plant-based diet, and avoid acute kidney injury. Tertiary is management of uremic symptoms and comorbidities. So we manage the uremic symptoms, we do the fluid management, we do the cardiovascular and nutritional therapy and pharmacotherapy. So these are the conventional drugs which Dr. Yuvraj has already discussed. The first drugs to be given in patients with chronic kidney disease who have a GFR of around of more than 30 is ACE inhibitors or ARBs. Then we go on to add calcium channel blockers. These are the things that everybody of us knows, been there since quite some time. So these are the newer drugs which are on the block. SGLT2 inhibitors and renal outcome, a comparison of randomized controlled trials. So this is canagliflozin versus placebo, dapagliflozin versus aceblo, DAPA-CKD and EMPA-CKD, that is empagliflozin versus placebo. So all these studies shows that there is a significant reduction in renal specific composite of end-stage kidney disease. Again this and again the same studies. And earlier all these flozins, they were investigated for diabetic kidney disease, but we all know now that they have been investigated for other forms of chronic kidney disease as well, except maybe for polycystic kidney disease, but for diabetic kidney disease, hypertensive kidney disease, in lupus, glomerular diseases, especially IgE nephropathy. So these are the drugs. Sometimes I write these drugs and the patient goes to the to the chemist, and the chemist says, "Doctor साहब ने आपको sugar की दवाई लिख दी." So वो कहता है, "Doctor साहब मुझे तो sugar है नहीं." So these are the drugs which are now being used for patients of chronic kidney disease, non-diabetic chronic kidney disease. So this is again, this about the CV and renal outcome with SGLT2 inhibitors. I have told you the main problem in patient with chronic kidney disease is poor cardiovascular outcome. So these are the drugs who have beneficial effect on all these other parameters also besides retarding the progression of chronic kidney disease. So when we talk of heart failure hospitalization, so mind it, these are the only drugs which are indicated for all types of heart failure, whether it's heart failure with preserved ejection fraction, whether it's heart failure with moderately reduced ejection fraction, or whether it's heart failure with reduced ejection fraction. So SGLT2 inhibitors for heart failure, for reduction in CV death, for reduction in 3-point MACE, and for renal outcomes. But it was seen that despite adequate BP and glycemic control along with RAS inhibitors and SGLT2 inhibitors, patients are even at the risk of CKD progression. So when given SGLT2 inhibitors, there is a residual risk. This is the residual risk, this is the placebo, and this after the SGLT2 inhibitors. So there is still a residual risk with all these three drugs, Canna, DAPA, and EMPA. So how can we lower this? So this is the other drug which Dr. Yuvraj was talking about. So this is the mineralocorticoid receptor antagonist. MR plays a key role in contributing to inflammation and fibrosis in kidneys. Finerenone, this is a newer NSMRA, targets MR overactivation and slows heart and kidney disease progression in patient with type 2 diabetes mellitus. So finerenone primarily targets and blocks MR overactivation, which slows CKD progression in patient with type 2 diabetes and chronic kidney disease. And this drug is going other trials for other indications for heart failure and others which will soon be out. So maybe in times to come, we will have this drug for other form of chronic kidney disease also. But as of now, this drug is indicated only for slowing the progression of diabetes related chronic kidney disease. So this is the fidelity meta-analysis of drug. There were two big trials, and it was clearly shown that the endpoint of CV outcome, there was a 14% risk reduction. For heart failure hospitalization, there was 22% risk reduction, and for kidney composites, there was 23% risk reduction, and for dialysis, there was 20% risk reduction. So it was concluded that finerenone on top of standard of care reduces the risk of clinically meaningful cardiovascular and kidney outcomes in patients with type 2 diabetes mellitus over a broad spectrum of chronic kidney disease. So we have ACE inhibitors, we have SGLT2 inhibitors, and now we have this NSMRA, that is finerenone. This is the other drug, GLP-1 receptor agonist. This is a multifactorial effect beyond glycemic control, especially relevant in patients with diabetic chronic kidney disease. So this is now available orally as well. Oral semaglutide is available in 3, 7, and 14 milligram doses and escalated every 4 weeks to mitigate gastrointestinal adverse events. The other drugs is the statins. So statins versus cerebral outcomes and renal morbidity among various stages of chronic kidney disease. It's conclusively proven in stage 1 to 3 of chronic kidney disease. SHARP study, it showed beneficial effects. The 4D Aurora trial in patients with dialysis patients with chronic kidney disease, it had a neutral outcome. So not indicated as of now in patients with dialysis who have an increased incidence of chronic kidney disease. So the famous pipes of renal protection, SGLT2 inhibitors, I've already told you, non-steroidal MRAs, RAS inhibitors, GLP-1 receptor agonists, and statins. So these are the must for all patients with chronic kidney disease unless they are contraindicated. So this is a beautiful article which was published in Circulation. To summarize, it showed that the incidence of MACE, hospitalization for heart failure, cardiovascular death, CKD progression, and all-cause mortality is significantly decreased when we use combination of SGLT2 inhibitors, GLP-1 receptor agonists, and NSMRS. So when we talk of pillar-based therapy, we have to use these drugs unless they are contraindicated. Few of the drugs which are under consideration is pentoxifylline, and old drug and a new opportunity. Pentoxifylline is currently indicated for peripheral arterial disease, but open label trials have shown beneficial effect in diabetic kidney disease and also non-specific CKD and chronic allograft nephropathy. So they cause decreased albuminuria and inflammation, decelerate in GFR decline rate, and preservation of anti-aging factors like Klotho, and our most important finding in diabetic kidney disease. This another drug which is being studied now. This is atrasentan, angiotensin 2 receptor. So atrasentan gives a weak signal for improving diabetic nephropathy. So this was a sonar trial in which 5,000 patients were studied, and they were initially given this atrasentan, and those individuals who have a reduction in proteinuria and no overload, they were then stratified to receive a placebo or atrasentan. And it was observed that atrasentan reduces the risk of renal events in selected patients with diabetic nephropathy at risk of developing end-stage kidney disease. Another drug which is under consideration is vitamin D analogs. So this is vitamin D receptor activation. The selective vitamin D receptor activation with pericalcitol for reduction of albuminuria in patient with type 2 diabetes mellitus, this was a vital study, demonstrated the additional antiproteinuric effect of pericalcitol in diabetic patient on stable treatment with RAS inhibition. TGF beta 1 inhibitor, so this is a favorite drug of pulmonologists, especially after the COVID. So Finerenone is an oral compound, has been found to inhibit TGF beta 1 production, and it has been now used in patients with interstitial lung disease, idiopathic interstitial lung disease. And this drug is now being extensively studied in patients with chronic kidney disease for its antifibrotic effect. Antioxidants have always been enigma. So drugs like Tempol, which is macrocyclic porphyrin, and Epsilon, which is a synthetic organoselenium, they have been studied in chronic kidney disease and they have been found to have some beneficial effect. There is all hype about the AI. There is a lot of words about the AI. So AI is coming in management of chronic kidney disease as well. So they can be of use in diagnostic assistance, for imaging, so making appropriate codes, then forecasting the CKD severity, kidney transplantation, and so forth. Novel therapeutic alternatives. So we have now a wearable artificial kidney. So this is a dialysis device that allows patient to have mobility and get dialysis while performing their day-to-day routine. Allows mobilization and continuous toxic clearance. They have good, patients have good hemodynamic stability. They weigh less than 5 kg. They have reusable dialysate solutions without needing large amount of water. But there are variations of blood and dialysate flows, and there's clotting risk of vascular access. A lot of work is being done on these variable artificial kidneys. Then xenotransplantation, we all know that pig heart, pig kidneys, pig liver is being studied, so it's there in nephrology as well. Transplantation of kidney from another species, mostly pigs. There was no signs of hyperacute rejection and stable urine output for a short period of time, but there was incidence of TMA, problem with creatinine excretion, and limited studies are there. The future of artificial kidneys, there is exciting new development in the field of artificial kidneys. So we have wearable artificial kidneys, biohybrid and implantable artificial kidneys, and regenerative medicine and kidney components. So this is a prototype of the wearable artificial kidney. There is further strengthening it, further making it better. So then it might be a belt-based device or a piggy bank device which we can use in years to come. This is about, bioimplantable artificial kidney is a device that can be implanted inside the body and performs the normal renal functions. The kidney project, a partnership between Dr. Roy's team at University of California and team at Vanderbilt University intends to accomplish the same. Their implantable biokidney utilizes a micromechanical system to reduce the size of renal tubule assist device and combines silicon nanotechnology and tissue engineering. So the take-home points is identify risk factors early for primary prevention by employing appropriate screening tools, especially serum creatinine, eGFR, and albuminuria, in a timely fashion for early diagnosis and intervention. Multidisciplinary approach is important to delay renal disease progression. So we have to have a multidisciplinary approach. Renal disease is multifactorial in nature, and therefore multiple pathways need to be addressed for comprehensive management of the patients. The ongoing development of innovative treatment brings hope of promising improved outcomes and enhanced quality of life of individuals facing kidney challenges. By a timely adoption of these innovative advances, we will not only preserve lives, but pave the way for significant improvement in quality of life for the patient. Waiting is delay. Acting promptly ensures a lasting impact. Thank you for your attention, please.
Thank you so much, sir, for the wonderful talk. And the house is open for the comments from the panelists and the questions. Sure, ma'am. Yeah.
So, EGFR, you mentioned was serum creatinine, but sometimes in very young people that we see with bodybuilders doing a lot of exercise, I've come across some patients who have a borderline young age, serum creatinines of 1.4, 1.45, varying over a period of time. So in them, if you calculate the EGFR through this method, they turn out to have a, stage 2 or stage 3 CKD. So there, what would you tell us? How static should that serum creatinine, because we've been told that's like a very important parameter. And second question was, when do you stop Finerenone? I mean, what is...
Yeah. So taking the first question first. So if we calculate eGFR in individuals who have a high mass, the GFR might be low and the serum creatinine might be high. So there sometimes we have to take the help of cystatin, because some of these patients might be taking a lot of creatinine, protein, and many of these formulas they have in creatinine as a protein. So they will have a high serum creatinine. So here if we have a suspicion that the creatinine is falsely high, then we can go in for cystatin levels or a radionucleotide scan that will give you the exact results.
So if the serum creatinine is high and the cystatin see your EGFR is normal, so then you're happy about it?
Yes.
Fine.
And the other question you said was Finerenone. So there are 5 F's about Finerenone. So eGFR of less than 25, and if the potassium level goes up, then we have to stop this drug. Potassium level of 5.5, if the potassium level is of 5.5, then we stop it, and then we can take measures like reduction in potassium intake if the patient is taking other drugs as well, and then we can again restart it. And if the patient again has hyperkalemia, then it has to be restopped.
So the literature says you don't start if it's more than 4.8.
Yeah.
Something
Yeah.
of that sort?
Data is very conflicting regarding this, ma'am.
I know.
Yeah.
I mean, their product monograph
I
says
think it's
don't start.
4.5. They say the
4.8.
GFR if the potassium is 4.5, you start with 10. And then you follow it over some time, and if it goes up, then you stop it. If it remains the same, then you can escalate the dose to 20.
Right.
So how frequently do you monitor potassium levels?
See, they say 4 weeks, but for me, I just, once I get it done at 1 week. And especially if those patients who have a borderline GFR, who are on other drugs, who are on ACE inhibitors, or who have a borderline blood pressure, then we have to be very cautious in such patients.
Sir.
Yes, sir.
Doctors and the general people, they are taking PPI left and right. They are available as OTC. They are available without any prescriptions. You go to the medical store, you just name that I want a DSR and you will get it. Now, what is the nephrologist viewpoint as far as the renal toxicity is concerned? Because as gastroenterologists, we don't really pay much attention to.
In fact, both neurologists doing Sompras D and plain Sompras.
Yes.
Because that is also domperidone keep taking.
Sir, there is enough evidence in literature now that if taken for a prolonged period of time, these drugs are nephrotoxic. We also, because many of our patients, they have anorexia, nausea, vomiting, starting in early stage of chronic kidney disease, so we avoid these drugs and we are more switching to H1 blockers, ranitidine. So I think these drugs should be avoided. Over prolonged period of time, they can cause.
But we have seen many prescriptions from the nephrologist, they using rabeprazole.
Sir, if the patient already has advanced, that's what I'm saying, the patient already has advanced chronic kidney disease, then मैं सबको कहता हूँ तो खंडर बन गया उसमें क्या ही आप कर लोगे. But again, we have to be cautious if the patient is early stage of chronic kidney disease and if the patient is not symptoms. So if the patient has anorexia, nausea, vomiting, then we have to give it, obviously. Sir, there's a question.
Your view on use of rock salt and black salt?
Yes, sir. See, rock salt and black salt, because we don't know what is the total composition. So it's like just Ayurvedic and homeopathic drugs. Earlier they were pure drugs. So now we don't know what is in them. So I would suggest my patients to take less amount of normal salt. A level teaspoonful is generally 5 gram. So I just ask them, it's best to have a food which is prepared without salt and you give them 3 to 5 gram and add as much as they want.
No, recently there's an increased incidence of use of rock salt and black salt.
So that's what now I am telling my patient not.
We should stop that.
Yes, I am telling my patient not to use rock salt, black salt, pink salt, Lona salt and Tata Light.
Comment from sir.
Himalayan water is also very expensive these days.
How to treat the anemia in CKD, sir?
So that's again a very big topic. First and foremost, we have to correct the iron deficiency. If there is an iron deficiency, we correct it. If the patient is able to tolerate oral iron, we give oral. And if the patient is not able to tolerate, we give IV iron. And then if all the deficiencies have been corrected, then we go on to give EPO, erythropoietin. And now we have hypoxia-inducible factors as well, oral drugs, so they can also be given.
So I have a
Usually
signal.
what we say, if you just go for the serum iron level, so in one group of the patient we get the normal serum iron level. In other group of the patient we have the low iron group. So what is the difference and what drugs should be given?
So the main is we have to see the serum ferritin and transferrin saturation. So if the patient, and in patient with chronic kidney disease especially, we target a higher serum ferritin. It's more around 400 to 1000 we have to target serum ferritin.
So I would like.
Actually what I say, when we go for the CBC,
Ma'am, it is
and,
always.
and we get the anemia, we go for the iron level. But by looking the CBC, we can decide whether there is a iron deficiency or it is a folic acid deficiency. And that depends on the Menger's index. If the Menger index is more than 13, it is the iron deficiency. If Menger index is less than 13, it is a folic acid.
So the problem with the
Therefore, we should treat according to the, and we can judge only by looking the CBC.
So the problem with CBC and chronic kidney disease patient is that many of these patients will have a microcytic picture because of the anemia of chronic disorder. So then it might be, we might not be able to judge it.
So I would like to end the session, thanking you to sir, with great session, great talk, great discussion. We will further continue discussion with a cup of coffee. Thank you so much.
Thank you.
I'd request Dr. V.K.Mishra sir to please give memento to Dr. Deepak Diwali. I would request Dr. Mishra sir to please give memento to Dr. Yuvraj Gulati. Dr. D.P. Agarwal sir. I would request Dr. Gulati to please give memento to Dr. Alok Pandey. Dr. Mansi. And Dr. Kirti Vardhan. We'll now be proceeding for our next session, which is gastroenterology session. But we don't have a break, so meanwhile high tea is being served outside. So you all can get your plates inside. For our next session, I would like to invite Dr. Shubhra Mishra as moderator. Dr. Shubhra did her TM Gastroenterology from PGIMER Chandigarh. She's certified by European Speciality Examination in Gastroenterology and Herpetology and Fellowship in Endoscopic Ultrasound at Yashoda Hospital, Hyderabad. Dr. Shubhra worked as clinical and interventional gastroenterologist at Department of Gastroenterology, Asian Institute of Gastroenterology, Hyderabad. Presently, she is gastroenterologist at GASTRO LIVER HOSPITal, Kanpur. Please welcome Dr. Shubhra. I would like to invite our panelist, Dr. Mayank Mehrotra. He's Senior Consultant Gastroenterology at Regency Hospital, Kanpur. He did his MD DM Gastroenterology from SGPGI, Lucknow. He has more than 15 years of experience in gastroenterology. Please welcome Dr. Mayank. Next, I would like to call upon Dr. Anurag Sachan as a panelist. Dr. Anurag is Consultant Gastroenterology and Hepatology, Paras Yash Kothari Hospital. Chief Consultant at Digestive Care Clinic, Kanpur. He did his MD DM from PGIMER, Chandigarh. Next, I would like to welcome Dr. Piyush Mishra, Senior Gastroenterologist, CN Gastrocare, Arinagar. Please welcome Dr. Piyush. I would now request Dr. Shubhra to please take over.
Good evening, everyone. So our topic today is diabetes and NASH, the therapeutic challenges. So as there's an increasing incidence of diabetes and obesity, which now we refer to as diabesity, we know that there's increased incidence of fatty liver also in these patients, and more incidence of fatty liver with inflammation, not just simply steatosis. So what are the treatment options? How long should the treatment be continued? When to stop the treatment? Is there any role of combination therapy? There are a lot of drugs which are being used in clinical practice but are not really recommended. Lot of drugs which have shown benefits in RCTs but have not really taken off in clinical practice. So I would like to invite Professor Gaurav Pandey, sir. Sir did his DNB gastroenterology from Amrita Hospital, Delhi, and now he's a professor at SGPGI Lucknow. So sir will be enlightening us on this topic.
Dr. Gaurav Pandey is Professor of Gastroenterology at SGPGI Lucknow. He's working with new treatment protocols for management of refractory ascites, recurrent ascites, hepatorenal syndrome, hepatic hydrothorax, and acute and chronic liver diseases. He's also using implementation of new diagnostic tools to differentiate infection versus inflammation. He has 54 international and national publications to his credit. Please welcome Dr. Gaurav Pandey. I would also like to invite Dr. V.K. Mishra, sir.
Sincere thanks to Professor V.K. Mishra, sir, for giving me an opportunity to discuss this. So the topic was NASH and diabetes. Before we move forward, sincere thanks to Professor Surikant, sir, to agreeing to delay his talk. I had to go early for some family issues later in the evening. So sincere thanks, sir. So coming to the first topic, NASH and diabetes. So the word NASH is basically non-alcoholic. So non-alcoholic is, or non before any subject, is not a good way to describe the disease itself. Before, probably when we were doing our residency, there was a term that the younger generation may not know. It was non-A, non-B virus. So obviously, hepatitis C looks a much better name than a non-A, non-B virus. So similar to that, till disease was called non-alcoholic, for a search of better word. So now coming to that, NASH, the name has been changed to MASLD, and why it has been, we'll just discuss and then go to the treatment options. So first of all, a question to the resident, all of you agree that MASLD or NASH and diabetes are linked, or it is a hyped thing? Linked? Why is it linked? Is it because MASLD has a higher risk of development of diabetes? Is it because they increase the severity of liver fibrosis? Is it because they cause more insulin resistance? Is it because those with fibrosis have a higher or a worse HbA1c control? Or is it because MASLD itself is a pre-diabetic condition? All of the above. Oh, excellent. Brilliant. So, very knowledgeable audience. Wonderful. It's all of the above. Now we'll just take a case-based discussion. We'll take a 58-year-old gentleman. He has deranged LFT. Ultrasound is showing grade 3 fatty liver, not a cirrhotic liver. He is on statins and telmisartan for diagnosis for dyslipidemia and hypertension for last 10 years. His only symptom is that he feels okay, but occasionally often tired, that's all, especially at the end of the day. So almost basically asymptomatic. These are his labs. He has a BMI of 30 plus. He takes alcohol of around 60 ml once a week. His OT-PT are 110, 105, but the platelets are 1,50,000. So these are his labs. Most of the things you know. So first of all, what do we call this disease? We have already discussed. It is not called MAFLD, it is called MASLD. It is metabolic associated steatotic liver disease and not a fatty liver disease. The F, because of its stigma, has been removed. So instead of fatty, it is because it has become steatotic liver disease. So MAFLD to MASLD. Is obviously to remove the stigma of the word fat, and the word alcohol has also been taken off. So the name change now sounds reasonable from NASH, NAFLD to MASLD. So MASLD incorporates the whole issue of insulin resistance, fat accumulation, and the whole metabolic dysregulation that happens. As previously we saw in the talk with Professor Diwan, a wonderful talk, CKD, again, the higher number of deaths is because of cardiovascular disease. Same is here, it's the whole metabolic profile that is growing. Diabetes itself is causing CKD, but the deaths are because of cardiovascular disease. So the metabolic dysregulation also has to be taken into consideration. This patient takes around 60 ml of alcohol a week. Can he be called an alcoholic liver disease person? How many of you agree that he can be an alcoholic liver disease and not a fatty liver, NAFLD or MASLD disease? So having alcohol once in a while, what is the basic cutoff of alcohol? How do we integrate them? That was again a challenge. So the new classification that comes in the umbrella of steatotic liver disease takes it into consideration. If he does not take alcohol, pure and simple MASLD. If he takes alcohol once in a while, less than 20 gram a day, he will again come in the category of MASLD. But if he takes alcohol to the tune of 50 to 60 grams per day, he becomes an alcoholic liver disease. What about in between? So a new terminology was introduced that was called MET-ALD, metabolic and alcohol-related liver disease. So MET-ALD takes into consideration patients who take alcohol in moderation. So now they have reasonably subclassified patients who take no alcohol, occasional alcoholic, moderate amount of alcohol, and have drugs or can be cryptogenic. So the whole umbrella is called steatotic liver disease and not a fatty liver disease. Now for fulfilling the criteria of steatotic liver disease, it is very important that they fulfill the criteria for metabolic syndrome. All of us are really well versed with this. You know, you have to have a high BMI, you have to have a high fasting serum glucose, blood pressure of 130/85, plasma triglycerides of 1.7 or more, plasma HDL low. Suppose a 30-year-old male walks into OPD with ultrasound report of fatty liver grade 3, SGOT is SGPT of 110/50, OT more than PT, but absence of all other metabolic parameters. He does not qualify as MASLD. He has to have one metabolic parameters to fulfill the criteria of MASLD. Just fatty liver on ultrasound will not classify him as MASLD. He has to have at least one of the 5 metabolic parameters. So the definition has changed now. So and MASLD and diabetes, has the prevalence gone up? Obviously, as you see, from a pre-diabetic to a diabetic, as the incidence increases, the incidence of MASLD increases. So more than 45% of MASLD people may have, of diabetic people may be having MASLD. Some studies show that up to 88% of patients with metabolic syndrome will have diabetes. So different areas have different geographical location, have different diseases. In short, the incidence varies from 50 to 80%. Patient having MASLD would have diabetes, so the prevalence is high. Now, MASLD and diabetes, are they more sicker or less sicker than patient without diabetes? So is the risk different? That's the other question. So if you look at MASLD progression, diabetes, hyperglycemia, hyperinsulinemia, and insulin resistance are all linked. So they make the MASLD progression faster, more rapid, with higher grades of fibrosis. So MASLD progression is increased when they are combined with diabetes. So clinically, in people with diabetes, we should look at waist circumference and waist hip ratio. If they are on the higher side, they may have higher risk of MASH and advanced fibrosis. These are important clinical subtle markers that we occasionally overlook. We give all the basic parameters, pulse, BP, but we never mention the waist circumference and waist hip ratio. Very, very important clinically to suggest that these patients may be prone for higher degree of fibrosis. So fat or fibrosis, which is more important, and what is the impact of diabetes on liver fibrosis? So large study done in 620 patients from 75 to 2005 showed that fibrosis is much more important as far as the morbidity and mortality is concerned. Look at the red line and the green line. These were the patients with advanced fibrosis.
So advanced fibrosis, even in absence of MASLD, has higher degree of morbidity and mortality. So fibrosis is critical for long-term outcome. Ultrasound showing grade 1, 2 or 3 fatty liver may not be as important as a portal vein diameter or a splenomegaly. So that is more important clinically to manage for simple things. No, we should not go on the grade of ultrasound level of liver, fatty liver. Again, looking at the combination of diabetes and advanced fibrosis. So people with diabetes and advanced fibrosis are at higher risk of liver cancer development and also are at higher risk of liver related events. So both of them are high in patients who have MASLD and diabetes. So more liver cancer, more adverse effect, more decompensation. So clinically, if the person that I showed comes to our OPD, what should be the next line of management? Should we get a fibro scan or a FIB-4 or liver biopsy or an ELF score? Yeah, absolutely. So simple test FIB-4, we look at age, AST, ALT, platelet ratio and look at the patient parameters. So we have just put these patient's parameters here to give you an idea. Platelet of 1,50,000, we normally don't assume that he would have advanced fibrosis. But here this person with his data that we have just mentioned here has a high APRI and a high FIB-4 score of 3.87. If we look at the classification, APRI of more than 1.5 high risk, FIB-4 of more than 2.67 is a high risk. So patient are high risk for advanced fibrosis, F3, F4 fibrosis. So the patient already has advanced fibrosis, though the ultrasound shows only fatty liver. An ultrasound does not show any features of cirrhosis, and ultrasound and the CBC shows platelet of 1,50,000. So a very important subtle clinical marker to suggest that this patient has diabetes, HbA1c 6.9 and has MASLD and is moving towards advanced fibrosis. The sensitivity specificity is pretty high in these patients. So now how to assess on OPD basis? This is a rough chart. Patient has advanced fibrosis, probably because of the chair you may not be able to see. But here he has stage 3 or 4 fibrosis. All these patients require treatment. We cannot wait for these patients. They have already developed fibrosis, they have advanced fibrosis, and they merit treatment based on that. Only fatty liver may not merit treatment. I'll remove that. So, only fatty liver we may reassess on a yearly basis. But once we have high FIB-4, patient has advanced fibrosis, he merits treatment. Apart from treatment for fatty liver disease, we also have to look for obesity, triglycerides, pre-diabetic or insulin resistance status, and he would require treatment based on his clinical status. So MASLD with diabetes, it has an implication on development of liver cancer and decompensation. Does it impact mortality? If so, how much? You know, a huge study. 11,000 plus patient with 27 years of follow-up. Amazing study. Hardly able to replicate this study. Show that if they have diabetes, they are prone to die much, much earlier compared to patients who do not have diabetes. Then depending upon the number of metabolic parameters, we saw the list of metabolic parameters 1, 2, 3, 4. Higher the number of metabolic parameters in that chart, higher the mortality. So apart from diabetes, they should be treated for all other metabolic parameters. The impact of diabetes in MASLD is great. This figure itself shows that 27 years follow-up. Now, if this is the condition of patient, he is of high FIB-4, LSM of 10, what should we consider as the primary driver of cardiovascular risk and mortality? Hypertension, diabetes, weight, cholesterol or sleep apnea? Anybody? We have to control what is pre-diabetic condition, hypertension, cholesterol. Excellent, weight. Weight has the biggest impact on mortality in these patients. So again, systemic review of around 19,000 patients showed that the first one, higher daily calorie intake was associated with higher morbidity, mortality, development of MASLD in these patients. Correct the weight, it had positively correlated with MASLD, improves morbidity and mortality. He had a BMI of 30. So how do we classify 30.4? So how do we classify his BMI? Normal, overweight, obese 1, obese 2. 1, 2. Obese 2 now. So that has changed because in Indian setup now 23.5 has been taken as cutoff. Above 23.5 he becomes overweight. The ideal waistline in men is 90 and women is 80. The waist hip ratio in men is 1, the waist hip ratio of women is 0.85. So things in Indian standards are slightly different from the Western status. So Western status is 25, again 25 to 30 and more than 30 to 35 and above. So here in our status he becomes obese 2 and not obese 1. So if he is obese, what should be the target weight loss that we should advise? 3%? Yeah, so basically it's around 10 to 15% because studies have shown that he has advanced fibrosis by FIB4. We can do fibroscan liver biopsy. But studies have shown that to alter the fibrosis, he has to have a weight loss to the tune of 10% and above. So if we are able to achieve 10% above, that's extremely difficult to achieve. But if we are able to achieve that, then we may assume that he would have some fibrosis regression. Suppose the patient did not have fibrosis. Again his FIB4 was less than 1.3. But again he was 90 kgs. His target would be smaller to reduce the steatosis or the ballooning inflammation on histology. So it's just how severe the disease is tells us how much weight loss he has to achieve to reduce his progression of MASLD and cardiovascular mortality. Once the weight loss comes down, it goes in the table of 12. If you reduce weight by 12%, HbA1c reduces by 20, more than 2 folds, 27, triglyceride by 36%, BP comes down by 6, cholesterol again by 12%. So it has impact on all the parameters of metabolic syndrome. Now approach to weight loss and the effect on liver. So ideally we should tell our patients to have a hypocaloric diet. What is a hypocaloric diet basically? It's around 1200 to 1500 kilocalorie per day. So residents, any idea? Suppose what does a bowl of vegetable contains? How many calories?
Depends on the oil.
Yeah, but still rough idea. Yeah, so basically one bowl of vegetable, you know, one bowl is a fist size. So we have various size of bowls available now. So fist size bowl is around 200 calories. But if you have paneer butter masala, it becomes 300. Okay. If you have fried paneer 400. So you get the hang of how things increase, depends upon the quantity also. And you have dal with butter, again it becomes 300. Otherwise normal dal and vegetables that you use at home is 200. And chapati is 100. So a 1200 to a 1500 kilocalorie diet is what is to be advised. Now suppose a patient is lean and thin. Do you again advise him to lose weight if he has high FIB4 and fatty liver? How much? Again, so it's not much for him because he requires more of exercise, though he has insulin resistance. So a 3 to 5% weight loss for lean NASH is good enough. Physical activity is very important. Again, 150 to 300 minutes a week or 75 to 150 minutes of vigorous intensity exercise should do the trick. Resistance training, resistance training or weightlifting helps to improve the GLUT4 receptors on skeletal muscles. They reduce the insulin resistance. So that again has an added advantage. So aerobic and resistance both go hand in hand. You can have 4 to 5 days of aerobic and 2 to 3 days of resistance exercise. So which dietary intervention is best suited for this person? Calorie restriction, intermittent fasting, Mediterranean diet, or low carb, high carb, low keto diet, high protein diet. So many fads are there on internet, WhatsApp now actually. Overall, not for intermittent fasting? Yes. Difficult now for intermittent fasting for diabetics, how will you do that? But how will you help a diabetic? No, he has to take his insulin at a particular time or OHs at a particular time. But that duration is there. It is difficult, absolutely. But overall, yeah, everybody is right, it's overall calorie restriction. Because all studies have shown that it may be low carbohydrate or a very low carbohydrate or a low fat diet. Almost all of them are equal. One is not superior to other. So it's almost equal in multiple studies and meta-analysis. Coming to intermittent fasting. Intermittent fasting is very good. Why it is good is because you don't have to alter the texture of food. You need not go to very low carbohydrate or a low carbohydrate or a low fat diet or a high protein diet. Because it's very difficult if 3-4 people are living at home, how can separate food be cooked for everybody? It is not practical. So intermittent fasting gives you that without altering the nature of the food that is prepared, you can still with intermittent fasting reduce your calories and lose weight. The problem is in diabetics because they are prone for developing hypoglycemia. This was a problem more because of the first generation OHs. Now the OHs, SGLT2 and GLP-1s, you don't have this problem. But clinically, the problem with first generation OHs remain. So in diabetics, low carb diet was better compared to intermittent fasting. If they are on OHs that do not cause hypoglycemia, they can as well go for intermittent fasting. So this is the only in-between line reading that has to be there. Now intermittent fasting is also of various types, 5 days eating, 2 days fasting, alternate day eating, alternate day fasting. Which is better? Or eating for 12 hours, not eating for 12, eating for 16, not eating for 16, eating for 8. So basically, now with a lot of focus is on cellular autophagy. A person got Nobel Prize for autophagy. That is actually the best. But it's very difficult to do alternate fasting. Most practical is 16-8. 16-8 you have enhanced insulin sensitivity. So that is most practical. But obviously, if you have cellular autophagy, it increases the fat metabolism, gives you longer life. That is mainly because of the autophagy. The Nobel Prize was there on autophagy last year. So probably that will be one of the better ones. Just finishing now. Exercise on NAFLD, it does not reduce weight by has lot of development, it reduces the insulin resistance, so it's again helpful. Improves the liver fat and LFT. Weight loss is only 2 to 3%. Exercise reduces hepatic steatosis. High intensity, that is when the heart rate is about 70 to 80% of your maximum tolerable heart rate, or moderate intensity like brisk walking, both are same. The duration is different. For moderate, you have to be between 150 to 300 minutes a week. For high intensity, you have to be between 70 to 150 minutes a week. Both are same. This is in short, around once you do regular exercise, it's around 3.5 to 4 times more likely to have a meaningful response. 150 minutes of brisk walking a week, it reduces about 3% of weight. A very important component is NEAT that we forget. It's non-exercise activity, walking while talking on telephone, having a quick dance when you are having a shower, walking up the stairs, not using the lift, all these, walking your dog around, these things we don't pay much attention to. Having a glass of water, going and taking the glass of water yourself, then asking anybody else to do that. So these form more than 63% of your energy expenditure on a day, and we just do not listen to that. You exercise only 1 hour a day. You sleep 6 hours a day. For rest of the time, what do? If you are a couch potato for rest of the duration, how will you lose weight? So NEAT is a very, very important concept that has to be inculcated in all the OPD patients and in our lives too, to help gain weight, lose weight rigorously. So now patient has tried everything, is not losing weight. Now options left for him. Surgery, endoscopic surgery, mobile app for weight loss, or pharmacotherapy. Pharmacotherapy, obviously it's great. So the drug, combination of vitamin E, SARO, anybody? Not much data on that, but clinically used very often. And obeticholic acid. What about GLP-1? Yeah, I'll just come to that. So first of all, we look at vitamin E, SARO and PIO. When should they be used? So vitamin E, the data is mainly in patients who are not diabetic. And SARO, obviously, it can be given in diabetes, but its effect on fibrosis is limited. PIO, the issue is it causes weight gain. So it defeats the main purpose of giving the drug. It has good glycemic control, but because of weight gain, patients are also not happy and you are also not happy. So that's the main problem with SARO. But the issue with vitamin E is, a trial with a median follow-up of 5.6 years showed that it reduces fibrosis. It was a retrospective trial, but it reduced fibrosis and transplant-free survival was much better and number of hepatic decompensation episodes were low. So vitamin E had that added advantage that saroglitazar and other drugs had not shown.